Hi, this is Elliot Fishman, and welcome to April 2024 CTisus quiz. It's hard to believe it's springtime already, and to celebrate spring, let's look at 10 terrific cases. The most likely diagnosis in this patient with a low hemoglobin is, well, when you look at the axial and coronal images, and in fact the coronal is a 3D volume rendered, what you see, if you look very carefully, is a loop of thickened small bowel. It's probably about 5 or 6 centimeters in length. I think it's better shown on the 3D volume rendering than the axial view. On the axial view, if you looked very quickly without being very careful, you might just assume we're dealing with unopacified bowel. When you look at the coronal volume rendered imaging, it's much more obvious. The thickening is bulky. It's not causing obstruction. It does not have the look of Crohn's disease. Crohn's disease gives thickened bowel, but typically under 1 centimeter. Lymphoma is a definite possibility. I don't see any adenopathy, but you can have lymphoma of the small bowel without nodes, though maybe less common. Lymphoma can be bulky, but I have to admit, if you said lymphoma, it would be a definite possibility. It doesn't look like ischemic bowel. The vessels all look good. There's no inflammation. The best diagnosis, and in fact the actual diagnosis in this case, was a small bowel adenocarcinoma. I know on outside CT scans this was initially missed. Remember, the time of diagnosis, often of small bowel tumors, is between 6 to 18 months after initial presentation. This case illustrates the importance of being very careful when you're looking at scans. No one said rule out small bowel tumor, but small bowel is an important area and an area commonly missed. The most likely diagnosis in this case is, on the axial views and on the coronal views, you see a soft tissue mass well defined within the stomach. Neuroendocrine tumors can be within the stomach. That's a possibility, but they're hypervascular, so that's not the case here. This is soft tissue density to maybe a little bit lower. It can be lymphoma, but lymphoma is infiltrating in the stomach. It's not a polypoid mass like this. Also, it would be more solid. Gastric duplication cysts are usually water density, and they're a bit more exophytic, but that would be a consideration. But the soft tissue density is not the typical appearance of a gastric duplication cyst. The most likely diagnosis, and in fact the precise diagnosis, is a gastric GIST tumor. The number one location for GIST tumors is the stomach, about 60 to 70% of cases. They're often exophytic, but they can be intraluminal, as it is true in this case. They also can be intraluminal and exophytic at the same time. They can ulcerate, they can perforate, they can bleed. They're becoming more common, and they're often incidental findings, as in this case. GIST tumors under 5 centimeters are typically going to be non-malignant. So this was a very nice example. The least likely diagnosis in this case is, well, what do we see? We see a cystic and solid lesion in the junction of the tail of the pancreas and body of pancreas. There also is possibly an enhancing lesion by the tail of the pancreas. As you look carefully, that lesion could in theory be an accessory spleen. But for least likely diagnosis, lymphomas are typically infiltrative. They're rare in the stomach, and they're solid when they occur. So to me, that's going to be the least likely diagnosis, because neuroendocrine tumors can be cystic and solid, and that extra lesion by the tail of the pancreas could push you to a neuroendocrine tumor. Serous adenomas are usually cystic, but they can have solid appearances as well, and solid and cystic often with vascularity, so that would be a possibility. And a mucinous cystic neoplasm, great location. Patients are usually in their 40s and more commonly female. They can be purely cystic with septations or have a more solid component, particularly if they have malignant degeneration. I think the easiest thing in this case is not precisely what the diagnosis was, which was in fact an unusual serous cyst adenoma, but the least likely diagnosis was lymphoma. The most likely diagnosis in this case is, well, what do you see? You see a solid and cystic mass in the head of the pancreas. You can see some prominent vascularity on the MIP imaging, and the vascularity tends to be around the edge of the lesion. This could be a neuroendocrine tumor. There's some vascularity, and not every neuroendocrine tumor is hypervascular. Lymphoma would be unlikely. Lymphoma, when it involves the pancreas, usually you see adenopathy, and it typically is hypovascular. Mucinous cystic neoplasms typically do not have solid components unless you have dysplastic change or malignancy. They're also more common in the body of the pancreas. They're not as common to be vascular. So I'm kind of stuck here. Serous cyst adenoma, well, we talk about cystic lesions, but here it's solid and cystic, and there is this solid component appearance of serous cyst adenomas. Often in those cases, the vessels become stretched around the mass, the so-called claw sign. And although to me, in this case, the differential diagnosis really focuses on a neuroendocrine tumor versus serous cyst adenoma, the best diagnosis and the correct diagnosis is serous cyst adenoma. I think that solid serous cyst adenomas are very, very difficult to diagnose, and this is one of those good examples. In this patient with recent onset of diabetes, the most likely diagnosis is. Now, without looking at the images, when you say someone has recent onset of diabetes, you always worry about pancreatic adenocarcinoma. But what we see in this case is no evidence of dilated common or pancreatic duct dilatation. We also see this low density between the body and tail of the pancreas, and this low density surrounding the gland. When you look at it in the coronal views, it's tubular. It's that classic cigar shaped. So without the dilated duct and discrete mass, this is not an adenocarcinoma. Again, would not be lymphoma. You could not explain the peripancreatic low density by lymphoma. Pancreatitis would be a consideration. And again, this is a form of pancreatitis, but the classic diagnosis and the correct diagnosis is autoimmune pancreatitis. These can be easily confused with cancer at times because they're mass-like. They can have dilated ducts. They can have elevated CA19-9. It's often a difficult diagnosis. Again, the way when you think about autoimmune pancreatitis, we are doing some work with AI, and that may be helpful. The way you treat autoimmune pancreatitis, you give the patient 40 milligrams of prednisone for 2 weeks, and the gland begins to get smaller. So always think about autoimmune pancreatitis. The most likely diagnosis in this 40-ish-year-old female is, well, you see a cystic pancreatic mass sitting between the body and tail of pancreas. It has multiple septations and does have the feel of what might be soft tissue within the lesion. You can have cystic neuroendocrine tumors, though I have to admit, without the enhancing rim, this really does not look like one. Serous cyst adenoma is a possibility. With serous cyst adenomas, you can get calcification. You also get septations. You typically don't get more of that solid component. This doesn't really have the look of a pseudocyst because of the septations. On the other hand, the age of the patient, the sex of the patient, the location of the lesion, and the septations push you to the correct diagnosis, which is a mucinous cystic neoplasm of the pancreas. These will typically be resected because of the common occurrence of malignancy in these cases. In this 30-ish-year-old, the most likely diagnosis is, well, what do I see? I see a solid mass, or for the most part solid mass in the head of the pancreas. I don't see any dilated common duct or pancreatic duct. The vessels nearby look good. Neuroendocrine tumor, again, you can have solid neuroendocrine tumors, but they are more vascular than this. This is typically relatively minimally vascular, so I don't like that. Serous cyst adenoma, usually they're more cystic, but it could be. Mucinous cystic neoplasm, not the best location, but the size and appearance could be. The other possibility is a SPEN tumor. Now, the age is older. SPENs are teenagers and 20s, but we've seen lots of SPENs, or solid and cystic epithelial neoplasms of the pancreas. We've seen them. They can be small. They can be large. They can look like many other lesions. They can have calcifications centrally or peripherally. It's a very difficult diagnosis when you get to older patients. You at least need to think about it. 90% of SPEN tumors are cured by surgery, so it's a very important diagnosis. Again, this case makes you think about and to remember that it's not only teenagers or patients in their 20s who get SPEN tumors. Also, I should remind you that SPEN tumors, I think it's roughly 9-to-1, female to male. The most likely diagnosis in this case, well, here we see a large cystic pancreatic mass with septations. This is not going to be a neuroendocrine tumor, okay? It's not going to be that. There's no vascularity. You can have cystic neuroendocrine tumors, but there's no rim enhancement to any great degree. Pancreatic pseudocyst is a possibility. There's no changes of pancreatitis, and it's pretty large. Those pseudocysts can be large, but it's rare for pseudocysts to have septations in this type of appearance, so I don't like that. A mucinous cystic neoplasm is a good thought, though this would be one of the larger MCNs. Also, they're more common in the body than the head, but it's a possibility. But the best diagnosis is a serous cyst adenoma. Large cystic lesion, head of pancreas, septations, more common in patients in their 60s and 70s. It's a benign lesion, but it can cause symptoms because it causes mass effect, as in this case, simply because of its size. A really nice example of a very large serous cyst adenoma. The most likely diagnosis in this 30-year-old with abdominal pain? Well, on both the axials and coronals, you see multiple loops of bowel that are thickened. This is with positive contrast. There's apparently some thickening of the terminal ileum seen on the coronal view, but it's the mid-ileum that really is impressive, and also jejunum. So what do you think about? Lymphoma is a thought. Lymphoma can be one zone or multiple areas, but usually it's bulkier. Ischemic bowel is a thought, but the vessels look good. Graft versus host disease can give you thickened bowel, but usually longer segments. You don't get the skip segments. You also get more inflammation in the mesentery. And to be fair, I didn't tell you the patient had a bone marrow transplant. And again, we always need to remember to look at the history. Crohn's disease is more common in the terminal ileum, but can be at single or multiple locations, can involve duodenum, can involve jejunum, can involve ileum. And this is just a nice example of Crohn's disease. In this patient with back pain, what's the most likely diagnosis? I think this is a difficult case because what I'm seeing is infiltration in the retroperitoneum, encasement of the iliac vessels, the IVC. Everything is stretched, particularly well seen on the 3D volume rendered, but it's not obstructed. There's no bowel obstruction. Bowel is at best displaced. Lymphoma tends to be multiple masses, not just simply so infiltrating, but it is a possibility. Testicular cancer can give large retroperitoneal nodes or cystic masses, but not this infiltrating process. So I don't like that possibility. Retroperitoneal fibrosis is a good thought, but usually that causes hydronephrosis by pulling the ureters more centrally. I don't see any dilated ureters here. It can also be infiltrative, more solid, at times a bit more vascular. I have to admit I can't really exclude it, and it's in the differential diagnosis. This case, the possibility of tumor is a real one, and biopsy is necessary. And when this was biopsied, it was a ganglioneuroma. I think a neurogenic tumor would be a good diagnosis. Lower density infiltrating process in the retroperitoneum, often encasing vessels, both arterial and venous. You got to think about neurogenic tumors. Sometimes they have bone involvement, particularly in patients with neurofibromatosis. Sometimes they're multiple, again, think neurofibromatosis, but not always. And this was a difficult case, but it was a ganglioneuroma. Well, those are 10 absolutely terrific cases. Hopefully you got them all right. More importantly, hopefully you learned something new from looking at those cases. And with that, I hope April is a great month for you. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.